protected, I guess. All right, so we're going to get started now and take a look at a very, very important point and important role of the nurse in with pediatric patients, and actually this has become across the lifespan issue, and that is providing immunizations. And we need to, start thinking about why immunize. All right, and it protects, immunizations protect against over 20, let me turn off the lights, 20 dangerous diseases. Can you name one? Measles, good. Well, we don't do smallpox anymore. Tetanus, okay. All right, so those are just some examples, and we'll be looking at some others. We're not going to actually go into the diseases today, just the immunizations. We'll talk about the diseases, I think, next week. Some of them, like measles and chickenpox and all, more specifically. But today we're just looking at immunizations. All right, so let me just back up one more. With this 2014, we thought that we'd gotten measles under control. Then there was a measles outbreak. Typically, there's, as far as measles cases in the United States, there's maybe 60 a year, maybe, if that many. In 2014, there were over 600 cases of the measles. The issue with the measles is for young kids that are not vaccinated yet. We're going to look at when we get vaccinations. Do you know when children get their first measles shots? How old they are? No, it's a year. Yeah, it's a year. So a child can get exposed to measles before that period of time and come down with it and possibly die because of pneumonia and other issues. So, and the issue there was in 2014 that people were traveling to other countries and then came back, brought the measles with them and spread them to people that had not been vaccinated. Now, why do some people choose not to get vaccinated? Say it, ma'am, Samantha? Okay, so there's a concern out there that vaccinations cause autism, all right? And you know that guy, that doctor that did that ended up losing his license over because it was false research that he reported, okay? And think about all the thousands, millions of kids as a result of his falsely reporting data that ended up not getting measles vaccination. So we still have people in this country that believe that they don't need to be vaccinated because they're potentially dangerous. And what are they counting on? Well, these people are counting on everybody else getting vaccinated so that they are protected, right? There certainly is a lot of controversies related to this issue. So what we're seeing now, particularly with measles, is that people go traveling out of the country, bringing it back to the unvaccinated ones. Somebody had mentioned smallpox. This is one of those dangerous, very dangerous, deadly diseases. This is a good news related to immunizations. Smallpox has been eradicated from the world. All the countries came together and worked together to distribute immunizations and wiped it from the world. I think that's just incredible. And now it's only found in labs. It's still in the world, but not in people, around where people can get it. It's in labs and locked up in places. So, but that's one of the good news. Then we talked about tetanus. Tetanus is a very, very painful disease that can, it's a bacterial infection, leads to death in 1 in 10. Because of muscle contractions and locking of the jaw. The other term for it is locked jaw. Patient cannot open their mouth to swallow in this situation, and they can, because of that muscle tetany can end up having fractures, bone fractures. Mumps can cause meningitis and deafness. And there's a theoretical thing that says it can cause sterility in males, if adults were to get it. Polio, again, polio has been pretty much eradicated from the United States. We haven't had a polio outbreak in years and years and years in the United States, but it's still in the world. All right, so that is why polio is vaccines are offered. This is a LA hospital respiratory ward during a 1952 polio outbreak when they put people in ventilators because the polio virus attacks the respiratory system and causes people to be unable to breathe. The paralysis, it causes paralysis respiratory. So all these people were put in iron lungs, they call it. Can you imagine nursing in this situation? Okay. We'll talk about polio again next week. They have like little vests now that people can wear that help them to breathe. Pneumococcal meningitis, another issue. Pertussis is one that has made a comeback, and as a result of that, and it's a particular problem for infants. So this is why now we have the Tdap vaccine that people must get. And are encouraged to get. Let me see, I think I have this. Now they call this, I thought this is an interesting advertisement in that they were talking about, Grandma, what a big whooping cough you have, and the issue of what's called cocooning babies by vaccinating everyone around the child for whooping cough as a way of preventing the spread. And mothers, pregnant women now are, the recommendation from the CDC came out about 2015, I believe it was, that all pregnant women for each pregnancy must receive a Tdap vaccine. And they recommend it during the 27 to 36 weeks. Thinking about what you had learned from the modules, any idea why they might make that recommendation for 27 to 36 weeks? Okay, so I heard somebody say antibodies. Okay, so what happens in the mom? Okay, so she forms antibodies, and then what? Passes through the placenta to the baby, and the baby has what type of immunity then as a result? Passive. Excellent. You need to know that for the test. What? Yeah, that's excellent. All right. So that's why then the mom, instead of giving it to the mom after delivery, they recommend it during pregnancy so that passive immunization can occur. All right. And now that, grandparents are encouraged, any kind of, babysitter that's going to be taking care of the child, all that's, everybody's recommended to get Tdap, taking care of children now. And this is the diphtheria. Notice a membrane in the back of the throat there. That's the issue with diphtheria that can then impact the airway. All right, so preventing, we have vaccines now to prevent all those diseases. Now, other reasons children are most vulnerable prior to 2 years of age because in some instances they haven't had all their vaccines. Another issue is that the children's immune system is still immature. But these diseases can cause permanent disabilities and in some cases can cause death. Can cause permanent disabilities such as deafness, paralysis, broken bones, pertussis from the coughing can cause hernias, children. All right, so those are some issues and harm that can come to them as a result of that. the children. Also protects the unborn and susceptible adults. Okay. Mumps we talked about as an example for adults. Okay. And we talked about pertussis just a few minutes ago as a way of protecting the unborn, having that medication. Cost effective, how would it be cost effective? Medicate. Yeah, less health care. So if you have a child that has permanent disabilities from getting some of these diseases, then there's a lot of health care that's going to be invested in them throughout their lives. We can prevent that with vaccinations. Also with parents having to take off time of work, that might become an issue too. There is a no shots, no school, no daycare laws that are out there. That would be, even though we know that there are papers that parents can sign to ask to not, for their child to be excluded from this law. All right, now let's look at, as nurses, we have an overview thinking about how important it is for these children to get their immunizations to protect them from illnesses. So we're getting ready to give them, because that is a nursing role typically. So we need to, and it's just not giving the vaccines, we have to do an assessment first. So we're going to assess the patient for allergies. Perhaps they've had a vaccine in the past, they had an anaphylactic reaction to the vaccine. We'll look at certain vaccines, if you're allergic to certain types of antibiotics, you should not take. Right? So assessing for their for allergies. Present health status, and just to bring out the handout that I gave you to refer to that. Okay. All right. We'll go to this in just a minute. Look at, there's a screening checklist there. I would notice these for testing purposes, and plus it's very valuable when you're talking to parents about immunizations. So we look at the present health status, and sometimes parents think my child has the sniffles, I shouldn't bring them in for their vaccine today because their immune system is already impacted by their sniffles, and that is not true. All right, child can be on antibiotics, they can have the sniffles, and still get their immunization. So it's whatever is considered to be a mild illness. And look at the back on your handout. It says, is the child sick today? It says there's no evidence that acute illness reduces vaccine efficacy. That's one we're thinking about. Why would we give something to a child and it's not, that causes pain and is not working? But that's never been proven to be the case. There is a precaution, though, with moderate or severe acute illness. And so this is where nursing judgment may come into play. The nurse is assessing, maybe the doctor, healthcare provider hasn't seen the child, and the nurse may say, could you, take a closer look at this child. I'm concerned that they maybe shouldn't have their vaccines today. But mild illnesses such as otitis media, upper respiratory infections, and diarrhea are not contraindications to vaccinations. Do not withhold them if they're on antibiotics. Important point there. Sometimes parents don't want to bring a child in under those circumstances. Number 2, looking at allergies. 3, has the child had a serious reaction to the vaccine in the past? All right. Did they have seizures, for instance, a very, very high fever? Okay. If the child let's see, if the child to be vaccinated is 2 through 4 years of age, has a healthcare provider told you that the child had wheezing or asthma in the past 12 months? So with this issue, any kind of nasal type of vaccine, like the live influenza vaccine, shouldn't be given. Does the child, has a child, let's see, if the child is a baby, have you ever been told that that child has had an intussusception? Do you know what that is? What is it? Yeah, it kind of telescopes back on itself, resulting in a blockage situation. All right. And with that, if the child has a history of that, then the rotavirus is contraindicated for that child, or it'll have to be done very, very carefully. There'll have to be some decision making about that. All right, if has a child, a sibling, or a parent had a seizure, has the child had brain or other nervous system problems? And so then we want to take a look at whether they might have issues with the DTaP. Okay. Immune problems. Cancer, leukemia is not recommended while a child with cancer is undergoing cancer treatment or under any kind of immune suppressing kind of treatment, that they get their vaccines. Why? Apply what you learned. Okay, so if they're in cancer and it's causing bone marrow suppression or other types of treatments causing immune suppression, what's the issue? Okay, so the immune system can't do its work to make the antibodies, right? Does that make sense? That's the issue here. So we have to wait until the child immune system is able to do its work. The other issue too is the live viruses can cause diseases in these children with immune system problems. All right. Then the same, kind of the same issue on number 9, in the past year, has the child received a transfusion of blood or blood products or immune globulin? Okay, again, you learned about this in your modules. What's the issue here? So with immune globulin, what type of immunity does that convey? Passive, right? So the body is not making the antibodies. And if you give them in combination, then again, it's going to impact the effectiveness of vaccines to work. So we have to look at where in the picture we give it. Some, for instance, was it blood products? The patient has blood products, you have to wait 6 months to give them vaccines. Right, because of issues with antibodies and all in the blood product and in the immune globulin too. All right, so is there a chance that the child could become pregnant during the next month? All right, and so all we need to know is a child potentially pregnant? Why would we need to know that? Who shouldn't get, what type of vaccine shouldn't a pregnant woman get? The live ones. So then, are we going to do then pregnancy test on all these teenagers coming in? No. It's not recommended. Okay, it's not found to be cost effective. So how are we going to get at this? Are we going to say to the girl in front of her mom, you think you might be pregnant? So what we would have to pull them aside, right, and talk to them about this separately, all right. And has a child received vaccinations in the past 4 weeks? Issue here. What is it, Akita? Okay, so we have the issue of minimal intervals between what type of vaccines? The live ones, all right, the live viruses. So have they received vaccinations in the past 4 weeks? So then we want to know what kind of vaccines they have because of that minimal interval issue. Is this ringing bells from, okay, good. All right, so that's the checklist. All right, so that's all on here. Okay. Patient teaching. So we've got to kind of go faster. Okay. All right. With each vaccine, the nurse is required, healthcare provider, to give the patient, the family, who's a guardian in pediatric situations, or if you're an adult, you should be receiving this as well, a VIS, Vaccine Information Statement. It's federal law. It's got to be done. Doesn't mean so that, and I have an example in your packet of the meningococcal vaccine information statement. So for every vaccine that the child is getting, one of these need to be given to the guardian. Okay? And what the issue here, and then it talks about, why, what it is, who shouldn't get it, what are the risks of the vaccines, etc. Now, you don't have to document that the parent understands the vaccine information statement. I mean, certainly if you have questions, a nurse should talk to them or refer them to the healthcare provider. But it has to be documented that they received one of these. And also, what's important to note, on the back of this, you see a date. That has to be the most recent vaccine information statements. And these do get updated over time. So this is meningococcal. This one, the reason I made a copy of this, just to make a point, is that this one was updated this year. Down here, on the bottom of the statement itself, right down there. Yeah. Where do nurses get, so this is on the vaccine information statement. Where do nurses go and get these vaccine information statements? CDC, all right? That's where these are given. So people in charge of clinics or doctor's office, wherever vaccines are given, must make sure that they are given updated statements, vaccine information statements, to their patients. Okay, so that is just, again, it's a federal law. And, there's some vaccines we'll look at in just a few minutes that come as combinations, right? Pediarix, Kinrix, there's, several out there. And for each of the vaccines that are in that combination vaccine, they must get one of these. Say it is, Twinrix, has hepatitis A and hepatitis B in it. So what you would do is make sure that you gave to the patient a hepatitis A VIS and a hepatitis B VIS. Make sense? There's no combination VISs. Those aren't made. So what nurses have to do is know what's in the vaccine that they're given and make sure that the family has that information. And so documentation will be that the parents received it and the name of the vaccine information statement as well as the date. That all has to be documented. Okay? Any questions about vaccine information statements or VISs? Okay. All right, so these are what parents are taught, how often vaccines are given, and common and minor side effects, serious side effects, when to call the doctor, healthcare provider, clinic, however it's set up, and treatment of side effects, and importance of keeping records. All right, now administration. Let me just say, too, before, and you're going to see this practice, I think, still at the Family Health Center, of giving Tylenol. And how many of you, maybe as parents, were told to give Tylenol to your child before they came for their vaccinations, immunizations? I remember I was told that when I was bringing my children in. It's no longer, practice is no longer recommended. Right. It has been shown, research has shown that it impacts the efficacy or the how well that vaccine works to give the child Tylenol beforehand. Right. So, but at the Family Health Center, they are still giving Tylenol, they were last summer, so I'm assuming that the practice is still there, so that's going to be part of your procedure, is giving the child Tylenol before you give them vaccines. I'm just telling you what the research says. Okay? What you might see in practice may be different. So, what the recommendation is, because we don't even know that for every child that they're going to develop, why do we give them Tylenol? Fever and maybe soreness or whatever, okay? So we don't know that every child is going to have a reaction, whether it's going to be a fever or whatever. So the recommendation is wait and see. The child has a fever afterwards, then go ahead and give them the appropriate amount of Tylenol at that time. Yeah. Well, certainly as nurses, that's what we're all about, and we'll talk about atraumatic care in a few minutes, but we have to follow the research too. Yeah. Yeah, nothing is recommended. Okay. All right. So as you get into the immunization videos, you'll see this. Administration of vaccines is either IM, sub-Q, or orally. What I like are the ones that can be given either sub-Q or IM, right? That's really nice. But we need to know which ones. How come? If we give one IM and it was meant to be sub-Q, we could render that vaccine ineffective. The manufacturers have tested it, and they know how the vaccine should be given. And some, if you give it sub-Q instead of IM, then you might have more of a localized reaction, a very severe localized reaction, actually, because it should have been given deeper. All right? So you, as nurses, you need to know which ones are IM and which ones are sub-Q. You will be tested on it. It's pretty easy. I'll show you. All right. See, IM is usually all the inactivated vaccines. Examples of inactivated vaccine, your hepatitis B, your diphtheria, your Hib. All right, there's only really 2 activated ones that we give. All right, or the live viruses. All right. And that is your measles, mumps, rubella, and your varicella. All right, so isn't that pretty much easy? So remember that the live vaccines, so you have to remember what the live vaccines are, given sub-Q. IPV actually can be given IM or sub-Q. And that's your polio vaccine. All right, so these are IM usually, I could put this up here too, IPV. You can move it up there on your notes, in your notes. All right, so we usually use a site with IMs, anterior lateral thigh, or the deltoid. All right, those are the recommended areas. The gluteus is not recommended, and particularly children that haven't started walking yet, because it's not a well-developed muscle. And there are some that if you give it, even for adults, sometimes adults have come into the clinic. I understand. I wouldn't know why they would do this and say, I want that hepatitis B in my butt. All right? I don't know why somebody would say that, but if you get a hepatitis B vaccine in your butt, it doesn't work. It has to be given in the deltoid. All the vaccines for adults are given in the deltoid. All right, but we can't give it in the gluteus. It doesn't work. All right, needle size, infants and children, minimum 5/8 inch. We have to look at how chubby the child is too. All right, and 1 inch in thigh or deltoid, and we use a 23 to 25 gauge needle. Sub-Q, site anterolateral thigh, outer aspect of the upper arm, like you do with your, insulin. All right. Needle size, adult and children, 5/8 inch to 3/4 inch, 23 to 25 gauge needles. So you'll need to be aware of those, particularly when we have lab. We'll review that again. Okay. So sub-Q we'll practice that in the lab. Then we have ones that are given in the mouth, and we'll look at that in a little bit, the rotavirus. All right, atraumatic care, very important. So we're always going to be positive with the children. It's not like, uh-oh, you're in for your shots today. No, you don't say that to them, okay? And you don't call them shots either, all right? Should be, what do you think would be better? What would be the issue if you called them shots? Yeah, they think they're going to get shot. They have very concrete kind of thinking. You're going to get your injection. You can call it a, big person name, all right? But it should be probably not shots. And somebody talked yesterday about a stick. I mean, that could be a problem too. Using soft, calm tone of voice, making eye contact, explaining why vaccines are needed. And you can call it a vaccine too. This medicine, or you're getting your medicine today, will protect you about getting sick. Be honest, explaining what to hurt. Do not say that the injection will not hurt. Okay? It will hurt, but just for a short time. A pinch, you might say. Order of injections, injecting the most painful vaccine last is helpful. All right? And the ones that tend to be more painful, MMR, PCV, and HPV. Tactile stimulation, rubbing or stroking the skin may decrease the pain in older children and adults. And administration technique, performing IM injections rapidly without aspiration has also demonstrated a reduction of pain. It's CDC and all these other agencies, Immunization Action League, they don't recommend aspiration, even for an IM. They say that we're not near any blood vessels, and there's never been a case of it being injected IV. And it was interesting. I was reading about this today. They say if you pull up and you get some blood, you're going to have to start all over again. And if you didn't do that, you would have to waste all those resources. I mean, it actually said that. Those are resources that are wasted and has never been shown to be dangerous. I'm just saying, you're going to be taught to aspirate, okay? But I'm just telling you that the research doesn't really support that. Yeah, well, I mean, I know how people feel about IMs and aspirations. Any other time, yes. You aspirate. But I'm just saying what the research says about this. Yeah, it is. Quicker in, quicker out. No. All right. Administration, not necessary to aspirate. We looked at that. That's a nursing decision. Do not mix vaccines. OSHA does not require a healthcare provider to wear gloves during administration. We wear gloves. And that certainly is a nursing decision, individual decision, but it's not like you're going to, there's going to be any issues. Certainly if that the child or person is infectious, or you have some sort of issue on your hands that you might need to cover up, but it's not a requirement. All right, and they do, and this is, I guess, an important point as far as saving resources during mass immunization programs. Like flu mass. There was a point in time we were doing mass immunizations for measles. I remember participating in one of those. Yeah, or the polio. Yeah, with the sugar cube. Yeah. So I'm just pointing out what this says. All right. If more than one dose given, use different extremities. May space injection 1 inch apart on same extremity. And they say, too, that ones that tend to cause more local reactions, like the MMR and HPV, some of those you might want to put on different extremities. So if there is an issue, you know which of the vaccine caused it. Vaccine storage. Many vaccines are refrigerated. Okay, do not store in a door. So if you're returning things to the refrigerator, don't put them in a door. If it's multi-dose, put it back in the refrigerator as soon as possible. And multi-dose vials are thrown out every day. They're not kept the next day. So that's what happens in clinic settings, that what's left in a multi-dose vial gets disposed of at the end of the day. How are they disposing of it? I'm not really sure. Whatever there's, protocols for disposal. Yeah. No, the multi-dose, they'll be packing them up somehow. Okay. Pre-filled syringe is not recommended unless we're doing like mass vaccination. And the issue with that is pre-filling leads to errors. All right, so that's why it's not recommended. And sometimes they don't keep as well in the syringes as they do in the bottles, the vaccine itself. Protect from light as well, because that causes vaccine breakdown. All right, so teaching, again, potential side effects. The minor side effects we can expect: mild fever, minor rash, soreness, urticaria, some fussiness, and irritability. Parents have to be taught, that that's going to happen. But if you have a child that they go home and they're inconsolable for hours on end, when they get them home, that needs to be looked at. If they have a fever, encephalitis, seizures, anaphylactic reactions, well, we're not tell parents their child's going to die, but that's, that is one of the possibilities. Very, very rare. We wouldn't be giving these vaccines if that was happening on a regular basis. All right, documentation. We need to, and this will be reviewed with you at the clinic setting, but the type, the date and time, lot number, expiration date, site, and VIS that was given, including date of the VIS, and then the nurse's signature. All right, so now we're going to take a look at the different vaccines that are recommended. And these are recommendations. Some are required. HPV, for instance, we're going to look at that in a few minutes. That's not on the list yet of required vaccines. The ones that are recommended, though, are the ones that there are programs that will cover those vaccine costs for families. The HPV insurance may or may not cover it, right, because it's not on the required list. Does that make sense? Okay, and we'll look at why with that one in a little bit. All right, so we have DTaP and Tdap, and so that has diphtheria, tetanus, and pertussis in it. We have hepatitis A, hepatitis V, Haemophilus influenza type B, the Hib vaccine, your HPV vaccine, meningococcal conjugate. There's so many now. And it used to be we called them baby shots, but that is a misnomer anymore, because we're giving these vaccines to children as babies, 4-year-olds, and then they come in again around 10 or 11 years old for more vaccines. Then we have what's recommended for adults. So it's kind of a lifelong issue now, not baby shots. Okay, so we have pneumococcus, poliovirus, rotavirus, and varicella. All right, so let's look at the different types. This is one that there are 2 different types. They both contain the same components, but they're given at different times. All right, so we have the diphtheria, tetanus, and acellular pertussis. That's your DTaP. All right, and then Tdap is has more tetanus in it, but it also has a booster for pertussis. And you understand that what happened with the DTaP and pertussis is they found out that over time that the vaccine effectiveness waned. And so then we were seeing people that even had been vaccinated with DTaP that were developing pertussis, right, and spreading pertussis. So then that's why they developed another vaccine to be given at an older age. So we have Infantrax, which is your DTaP, which is given ages 2 months to around 7 years. And then Boostrix and Adacel are your Tdap vaccines, which are given after at 10 years or and older. So that's the booster shot and vaccine. And so everybody is it's recommended that everybody get a Tdap, all right, after 10 years of age, and then tetanus after that for the rest of your life, like every 10 years. Okay, does that make sense? So DTaP is for the babies, okay, and the 4-year-olds. And then after that, we do boosters with Tdap. And then once everybody has one shot of Tdap, then we do boosters for tetanus for the rest of the individual's life. Okay, and that's TD, with a tetanus vaccine. Make sense? Okay. Then we have combination formulations, and the move now in vaccine vaccine providers, what the CDC is really pushing of these combination vaccines, right? Because they can encourage people to come back. Sometimes, if you don't give a combination ones, I mean, the child could get stuck 5 or 6 times. It's awful. They're like little pin cushions when they come in. All right, so we give these on combination, less traumatic for the child and parent, and and it just, I don't know that they're cheaper or anything, but they tend to make people come in more for the vaccines. So combinations, your Pediarix is DTaP, Hep B, and IPV. Then you have your Trihibit. So you'll see that at the clinic, and every clinic has their own combination products that they bring in. Precautions, you can look through that. This is one with neurological disorders that come into play, encephalopathies. All right, when given DTaP, 5 injections beginning at 2 months. If it's given after 4th birthday, come in, present, we don't need to give them a 5th one. TD every 10 years. After DTaP series as a baby and 4-year-old, and booster dose with Tdap, then we start our TD. This one, and this is another just a pointer as far as vaccines, that when we look at how much is 0.5 milliliters. That's pretty much across the board except for hepatitis B vaccines. There's one, I think, can give a CC depending on the formulation. But as a general rule, 0.5 cc's or milliliters is what you're going to be given with each vaccine. All right, hepatitis A. All right, I didn't look it up this year. I don't think hepatitis A is required. Does anybody know in South Carolina, are we requiring hepatitis A for the children? I don't think so. Right, I believe that's still the case. But it depends on where you live in the United States, whether that's one of the required ones to get into school. Vaccination hepatitis A for children 12 to 23 months. Given 12 months and 23 months, 2 doses between them, 6 calendar months apart. And this is not the same as 24 weeks, all right? They actually count calendar days. The only time that days are counted, I believe, was for a month. It was 28 days. A month was considered 28 days. And after 28 days, then you start counting calendar months. Yeah. And that's important for nurses because you count, actually, if it's a 3 months, say the patient's to come back in 3 months, then you count to make sure, and it's from the 3 months on the date that it was given. All right. What about the grace period? Okay, so 4 days. Remember that? So if they come in early to the clinic, remember, intervals are very important, spacing. So if they come in 4 days early, they have a 4-day grace period. If they come in 5 days early, can't give it. They got to come back. All right? So remember that grace period issue for any of these vaccines. All right, hepatitis B. All right, this is protection. All of us have had that. When given first dose at birth, that is standard of care. What CDC wants to happen for every child born in the United States is that there is a birth dose given. All right. Doesn't always happen. There might be a reason not to, but this is considered to be standard of care now. Second dose is 4 weeks after the first dose, and then third dose 16 weeks after first dose or 8 weeks after second dose. And this is what makes, you have to documentation is just so important with vaccines because you don't want them coming in too early. They can. That's the minimal interval. Okay, remember you can go longer, so they can come in at if there's in there at 1 month for whatever reason, they can give it to them, but it's not wrong, certainly, to wait until the 2 month because spacing them longer, remember, that doesn't have an impact. It's when it's too short, the intervals are too short, that it becomes an issue. Okay. All right. And so the third dose. So say the child gets, first and second dose. Maybe they get their birth dose. They come in at 2 months or 3 months, get their second dose, and then we don't see them for a year. Do they have to start the series over again? What do you think? Let's take a vote. Do they have to start the series over again? How many say yes, they do? Okay. How many say no then? The rest of you say no? How come? Yeah, they're catching up, but remember, it's the intervals that count. If it's the longer, it doesn't matter. Too short is what matters. So that's yeah.
So they made me start all over again.
Yeah. Yeah, I mean, if the documentation does, come into play. I'm just saying if you have documentation of the 2 and you've missed the third dose, you can get that third dose at any time. Yeah. All right, but that's an important point to know with vaccines. All right, administration, dosage depends on formulation, so we have to look at that. Give IM, remember this is gluteal muscle, we don't do that. It's counted as invalid if it's given in the gluteal muscle. All right, follow-up antibody titers may be done, and this is 1 to 2 months after third dose, not as soon as you get it. You need to wait a little while for those antibodies to get in your system and then get the antibody titer done. After that, it's not as accurate. So, and I've had my series done years and years ago, and I probably, when I would go and, at the time I had antibodies, but if I go now, it probably wouldn't show anything. Doesn't necessarily mean that, and it doesn't mean, they don't recommend us taking it again, it's just that it doesn't show up on testing after a certain period of time. The most accurate is done this 1 to 2 months after the third dose. All right, Hib, prevent Hib infections. Let's see, contraindications. We don't give this to a child younger than 6 weeks. All right, but 2 months we can start it. When administered, first dose at 2 months, 4 months, 6 months, and 12 to 15 months for a total of 4 doses, may be administered to older children who are undergoing chemo with HIV and asplenia, just to protect them. Administration, we need to, it's IM, refrigerate it, 0.5, and there'll be directions. Some will come with a diluent, okay, and you have to mix them up. And only the diluent that the manufacturer sends with it is what's to be used. right? And you'll be helped with all that when you go to the clinic, but that's just part of knowing it. All right, HPV. And this is for human papillovirus, all right, which can cause cancer and venereal warts. We talked about this last semester. HPV now has two different types of vaccines. The Gardasil has one that's for 4 viruses and 9 viruses, and it just depends on the clinic or the healthcare setting which ones they might carry. So as a consumer, you'd be asking that because which would you want? Want the one that gives you the most coverage, don't you think? All right, and then there's Cervarix too. All right. So the indications: prevention of cervical cancer caused by HPV, Gardasil and Cervarix are good for that. Through age 26. After age 26, people can't get HPV anymore because the assumption is that you have already been infected. That's the assumption. Well, the assumption is you've had sex, okay? By then, and you probably developed, have the HPV already. All right, prevention of genital warts in males and females, and that's Gardasil. Cervarix is not indicated; doesn't have that indication. All right, and vulvar and vaginal cancer prevention, Gardasil through age 26. All right. So those are what it's called for. So let's see. Pregnancy, let me see here. Pregnancy, not recommended. We don't have enough research yet to know if it's safe. Because this is a fairly recent vaccine that's come out, the HPV. All right, so when administered is 9 to 11 years of age, no older than 26. All right, so controversy here, kind of difficult to talk to your child perhaps about why you're taking them in for a vaccine at 9 years of age, okay, with for human virus, for this. What do you think parents should tell them? They're getting other things too, perhaps at this time. Meningococcal. Yeah, you could tell them that we're going to give you a medicine that can prevent cancer. All right. So this one, administration, so there's 3 injection, dose 1, whatever the elected date is, they come in. Dose 2, 2 months. Today after dose 1. So if you come in November, let's make it easy, January 2nd. So when do you do for your second one? March 2nd. Okay. All right. And then dose 3, 6 months after dose 1. So it's January 2nd. So, it says 3 to 6 months. So the earliest they could get it would be when? This third dose. So they get it January 2nd. So they get it 3 months after dose 1. Okay, all right. All right. It's 3 to 6. Yeah, the earliest they could get it is at dose 3. I'm sorry, I'm reading it wrong. So it's 6 months. I'm sorry, 6 months after dose 1. All right. 0.5 IM in the deltoid. This one, I'll have to say that if you have experience this summer of giving it in the clinic, that this is one that teenage girls tend to have issues with fainting after. And anything that you give to a teenage girl tends to cause fainting, okay? And that is because of the anxiety and pain. And the reason to bring this up is there was a young woman, teenager, that had this went out into the parking lot and fainted, hit her head, and died. All right? So, the recommendation is after particular anything with teenage girls is you have them sit still for 15 minutes because usually when they do the fainting is within 15 minutes of getting the injection. That's what the studies have shown. So make them sit still for 15 minutes and then let them go. All right. Meningococcal MCV4. This is the one that people that live in close quarters can get a meningitis. Menactra and Menveo are the types of vaccines available. All right. So this is usually around 11 years old that we're giving it. And then certain colleges may require that kids have this before they go off to college. All right. When given, recommended time of administration is at around 11 or 12 or around age 15. Think of it is, I mean, if they, they're 15, I might quibble about waiting until 16. Booster dose, because then you just have to give one injection. They've been fine, they're not in close quarters, don't seem to be at risk. You might want to take a look at that because if it's given 11 to 12, they're going to have to come in for another injection. All right, booster dose, if that's what's recommended. Okay. Administration, 0.5 milliliter IM, Menveo is mixed, and it's kept refrigerated. MMR, measles, mumps, rubella. Okay. This one has issues with if the person has a thrombocytopenia or history of that, or thrombocytopenia purpura. Pregnancy, we don't give it within 5 months of blood transfusions and any previous allergies to vaccine, gelatin, or neomycin. So that's why we have to do our assessments. First dose is at 12 to 15 months. Why are we waiting until 12 to 15 months to give this vaccine? What's the theoretical reason? Yeah, passive immunity. So they still have immunity from their moms until about that point in time. I think that's interesting considering that, it's babies and infants that get the measles when they're exposed to, people with measles. But second dose at 4 to 6 years. Then we have any adult after 9 should get at least one dose of MMR if they're born after 1956. I think that's all been taken care of by now. This is 0.5 milliliter sub-Q because this is an live virus. Okay, must be reconstituted with proper diluent. This is refrigerated and protected from light. Then we have our Prevnar. All right, and this is, they used to call it, and maybe still in some circles, called the ear infection medication, vaccine, because it's pneumococcus is one of the more common cause of bacterial ear infections. All right, so prevention of infections caused by pneumococcus in children born birth to 23 months. After 5 years, we don't give it. Cochlear implant, kids with cochlear implant should have this vaccination. Okay. This one is, again, an inactivated, so it's IM, 0.5. Polio, and this is the only one we have now that we are given is the inactivated polio vaccine. That's a killed virus. What had happened several years ago is that we had the live vaccine injection that people were getting, and we ended up with people getting polio from the vaccine. So they took that one off the market, and you cannot get live polio vaccines in the United States anymore. It's all inactivated polio. So this is a routine immunization against polio. Neomycin, if a person is has allergies to neomycin or streptomycin, they shouldn't get this vaccine. This one is administered at 2, 4, 6 to 18 months, and then again at 4 years. So notice that there are 4 injections for this. You'll need to know those time frames, and I have in your packet the schedule. All right, so I would advise you maybe to bring that with you, even though the clinic will probably have that, but it's still a good reference to kind of think, okay, I have a 4-month-old here, so what are the vaccines that I need to be thinking about for this 4-month-old, and you can look at your visual. IPV is 0.5, can be given sub-Q or IM. All doses should be separated by at least 4 weeks. Okay, again, minimal intervals. So, and the implication there is, say that they are getting ready to go out of country, right? And they're planning a trip, and they need to get these vaccines taken care of before they leave. And this could be an adult too. So they need to know that they, need to plan ahead and have at least 4 weeks allotted so they can get their vaccines done in time before they take their trip. All right, then we have rotavirus, and this is the only oral vaccine that we have now. Okay. And this is a vaccine against rotavirus infection, which causes a gastroenteritis, most common cause of diarrheal illness in babies. Okay. We talked about intussusception, that would be a contraindication. This one is given at 2 months and 4 months if you have the RV1. If you're given RV5, that type of injection, it's a 3 months course. Minimum age first dose is 6 weeks, and it cannot be started after 15 weeks of age. All right, so all that needs to be taken in care of in consideration when planning for this one. So it's given PO, provided in a squeezable plastic dosing tube, and I think I have pictures in here of those with the rotavirus oral administration. You can take a look at that. Okay. Now, what do babies tend to do when you give them stuff? They tend to spit out. So with this one, it says, do not repeat dose if infant spits out or regurgitates the vaccine. It's considered to be a valid dose. You got it in their mouth. Yes. And you don't know, I guess the reason they say that is because you don't know how much they swallowed. Okay. Okay, then we have our varicella, our chicken pox. Almost done. So this one is a vaccine, it's a live vaccine for individuals 12 months and older. And it can, if somebody has been exposed to chicken pox, be given for somebody that has been exposed if they get it within 5 days of exposure. All right, and there's contraindications there when administered. So we have our first dose at 12 to 15 months, and then the second dose between 4 to 6 years of age. Adolescents and adults, they have to have 2 doses at least 4 weeks apart. Okay. Again, that interval is important. Administration is sub-Q. This is a live virus. So you all picked up which are your live viruses and which are your inactivated. You kind of got that in your head. Okay. So it's 0.5. This one they say change the needle prior to administration. That's not typically seen when giving vaccines because they seem very concerned about reserving resources, but this one says that. Vaccine should be used within 30 minutes of reconstitution. All right. Then I wanted to just show you the different types of combination vaccines that you might come across. And what they say, too, with these combination vaccines is that it's fine to give more doses than what the child needs. Okay, that's not necessarily the best case scenario for the child, but it's not against policy. You know, it's not going to hurt them. All right. So this one, and this is a good example of that. The Pentacell, you give them 4 doses, and then 1 dose of IPV and DTaP at 4 years. We talked about DTaP, you have to give 5 doses, but IPV, it only calls for 4. All right? But if you're giving the child Pentacell, they end up getting 5 doses of IPV because we can't skip this one at 4 years of age. Okay? So that's just an example of that. Pediarix, Kinrex, which is DTaP and IPV. This is a good one. So you have the Kinrex, because what do we say? We have to give a dose, especially if they've been on Pentacell. Then you have to give them a dose of IPV and DTaP. So just give them 1 injection with a Kinrex. Okay. Proquad, this is MMR and varicella. Okay, again, are live viruses. There's some controversy with this Proquad because the 12-month dose they found was associated more with a child having high fevers and seizures. So what they say is that you can give them just the regular MMR varicella vaccines at 12 months separate, and then at 4 years give the Proquad. May work better and prevent some of that. So Twinrex is your hepatitis A and B. All right, so I have on here some questions, and I'll put out so you can. We're out of time, so you can go through and answer those questions, and I'll put out the answers later for you. All right, for the tests. But these are the type of things that you need to know that we didn't from the modules that we didn't necessarily spend a whole lot of time talking about in class. Okay, all right. So, did everybody give me the